This is the case of duodenal neuroendocrine tumor. Do we have the history slides? Okay, so this is a case of a duodenal neuroendocrine tumor which is located on the posterior wall. You can see here I am going with a cap, and I have with me Sham from Muscat.
Yes, hello, hi, how are you?
And so you can see here he will guide me. What do you think about this lesion, Sham?
Yeah, knowing the history that this patient had sigmoid adenocarcinoma in the past,
Yeah.
and this was an incidental finding, the EUS was essential
Yeah.
to rule out METs as
Yes,
well.
yes.
But the FNA showed that this is a neuroendocrine tumor.
Yes.
And so we decided to go for the full thickness resection device to achieve R0.
Okay, so we have many options available to treat neuroendocrine tumors. One is band EMR, which is the most easy one, but it is for only submucosal lesions. But those who are touching the muscle, we need full thickness resections.
Yes,
and duodenal wall is very thin, and doing ESD in duodenum is quite challenging because you may perforate. So other options are to do freehand EFTR, that is full thickness resection, but we have to be ready with the closure devices. So here we have a device which is over the scope device, and this is known as OTSC FTRD device. So I have mounted a cap and I have gone into the duodenum, and I'm infacing the tumor there, and I will just try to do, and I have marked that area all around. You can see there's markings are there. Those markings were done by force coagulation, and then I am trying to do a grasper. I use the grasper with this to bring this into the cap. So I must go inside the duodenal pylorus, and then enface it and do gentle suction so that I can see the mark. You see that the mark, you can see the mark
yes,
there?
Yes, absolutely.
Yeah.
So you can see it right at the rim of the cap here.
Yeah, so that's the mark. So I have two types of mark. One is the last on the distal anal side, and one is on the this side, oral side. So I'll do gentle suction to bring this inside here, and then I'll use this grasper to bring it open, please. Close. So I'm just bringing them inside, you see, with the suction, gentle suction, and so once it is quite, so I'm just doing a gentle grasper, and then I'll do a sequence of events that is known as to apply the clip, and as soon as I apply the clip, I'll ask, I see the blue marker there.
Okay, so you can see the blue marker here.
No, I got
Wait,
it.
yeah, there we go.
That's a quite hard tumor. Can you be, I'm not able to hear you. No, now very faintly I can hear you. Yeah. Yeah. Yeah, so neuroendocrine tumor have to be removed according to the guideline, and the options available to us are either to do a full thickness resection or to do, so that's the problem with the grasper here. It brings a lot of bleeding. Open, please. So I'll go back and suck out all the bleeding. So grasper close, please. Grasper close. I'll bring in. I'll reposition myself again. Suck out the blood from the anterior wall.
Do you want to change the position maybe? Put it supine, will it be easier?
See, now the tumor is coming in.
And yeah. So now it's okay.
Open, please. Open. So now the tumor is in. Close, close, half close, please. Open. Close. It's quite hard tumor, and okay, so okay, open. Mm-hmm.
All right, okay.
Yeah, so we'll try to do.
We tried it, it was big. Yeah, it was big actually, because it's about one small lesion.
So sometimes what happens is once you grab the tumor with the grasper, it causes mucosal ulceration or the erosions and it bleeds. So what I do is I wait for 2 minutes for the bleed to stop and do proper suction. It's better to do suction and then wash this area like this, just to be sure where we are. Yeah, but I will finish it otherwise. Pardon, can you tell it?
Yeah, it has to be removed, yeah.
Yes. Yeah, because these tumors are prone to metastasis, and it is mandatory to all. If you see the gastric neuroendocrine tumor, they are classified into type 1, type 2, and type 3. The type 1 are associated with atrophic gastritis, and they are not mandatory to be removed. Type 2 are associated with MEN. Again, it is not mandatory to be removed because metastasis potential is less. Type 3 gastric NET, all has to be removed, while duodenal NET, all have to be removed. So I'm just trying to have the best position. How do you know? In duodenum there are two classifications. One is periampullary, anything around the ampulla of 2 centimeter, they have to be dealt with surgery because there is high chances of lymph node metastasis, and the duodenal NETs needs to be removed by endoscopically if they are less than 2 centimeter in size. So I'm just trying to suck like this, and then I will apply. Just to make sure that everything is inside. And now I hold this open.
Yeah,
Close,
okay, sure.
close. Yes. I'm trying to pull. Okay. I'm not able to. What do you think is in?
Yeah, I think we have to bring the lesion higher up there, yeah?
More I have. I think it's in. Open.
Yeah.
Oh. Close, close. There is, we do more of freehand. Yeah, yeah, I can hear you. So this is a very challenging area, which the question answer is I don't have, because at least 20 cases you must do. I'm just pulling, pulling, pulling. The position is slightly difficult for me. Okay, so what I am doing is I'm repositioning suction. Yes, yes, Pradeep. Yeah, yeah. I unfortunately that is not available here. The same. So yeah, 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 yeah. So I'm seeing this tumor is now in. Open, open, please. Yeah,
Okay, go ahead.
1 minute. Give me 1 minute, please. Close. Yeah. Open. So I'm trying to grab this. Close. And then bring. It's quite hard tumor there. So I have to use some suction. No, no, not one. No, no, no. It's
No,
type 3 is in the stomach,
in the stomach only. The
not in
classification
duodenum.
applies to the stomach.
It's quite hard. It's not coming inside. Now see, I'll
Now I
just,
think this
yeah,
will,
yeah,
now
okay.
it's, okay,
Open,
open.
close, open, close, close. No, it's not coming. Open, close. No, it's not coming. No. Yeah, I can you can change and then I'll see. To cut off the blood supply. Now, advantage is that this is quite a safe procedure and the cap size is slightly bigger and suction is allowed to do in band EMR, because if you do suction, you will not suck out the muscle mostly and you can apply the band. While in FTRD device, you are supposed to grab the lesion, collapse it and bring into the cap. While the hard lesions like neuroendocrine tumor, they are non-collapsible. So the size criteria of 2 centimeter is not good for FTRD device. It may be 1.5 to 1.2 centimeters, but not more than that. So this procedure is known as band ligation without resection. And can you hear me? Okay, so in this case, what we do is we do biopsies, make sure that is a grade 1 NET, and apply banding. And this is good for multiple lesions also, as I could see one more lesion here onto the, here you can see this is another lesion which can also be treated like this. So what I do for multiple lesions, I use this technique. Can you see there is a lesion just behind the pylorus? This is another lesion, so I'll just suck it and apply the band here. So this also becomes okay. Can you, yeah, please go ahead. I'm not able to hear you, unfortunately. Can you be a bit louder, please? Or somebody can relay the. We can, but as I said, once we have a proper biopsy available onto the lesion, it is just we are increasing the chance of perforation. But in our series, what we know do is bend, that is known as BLWR, bend ligation without resection. But the prerequisite is that we must have good biopsies, pre-operative biopsies, and a good DOTA scan. If DOTA scan is taking up these lesions very high, that means they are well differentiated. And biopsy, which we have taken, is showing low KI index. That means these lesions are safe and can be managed like this. This also same. It becomes ischemic, and then you will find after 2 months nothing is there, and you do after well, that nobody has seen serially, but we call our patient after 2 months and everything is gone. We do DOTA scan, we do check endoscopy, and we are able to remove majority of these lesions without any long-term, and there are many literature available also for band ligation without resection. So this is the safest method, but this lesion was slightly bigger for FTRD, and it was not coming into the cap, and more I was pulling. Suctioning was not allowed. I was doing suctioning, but with this band ligation you can treat multiple lesions like this. Somebody has to relay the question again. I'm so sorry, I can't hear. Yeah. If there is a visible lesion, mostly in our series, we do a scar biopsy, but we morely depend on the DOTA scan. If DOTA scan is negative, we don't do. And these patients respond so well to this treatment that we have stopped doing EMR. Now, once you do EMR, you must close because the duodenal wall is so thin, and then you have to close with either OTSC, and these lesions which are just behind the pylorus, they are very difficult to do OTSC closure because they may cause the partial blockage of pylorus. So in my opinion, multiple lesions, well differentiated, proven on biopsy, multiple lesion can be treated like this. But FTRD, the advantage is that you will get a full thickness resection, the muscle, and your pathologist will be able to tell us about the R0 resection, and you may not require a more strict surveillance. But they are good for anterior walls because OTSC on posterior wall is slightly difficult, the FTRD device, and the suctioning won't work on posterior wall that well because you are not able to approximate. And then we must have all the facilities for closure available. FTRD device, another disadvantage is that once you apply it, the clip is difficult to remove, and the further surveillance become difficult. So once there is a big scar with clip, you cannot do good surveillance.
Right,
and even
absolutely.
CT and other things will not pick up. So for these lesions, I think this is also a good option.
Yes.
Is there
A good
any
note.
kind of follow-up you would do, Dr. Mahan? Like, for example, chromogranin A,
Yeah.
if you have a baseline, irritated,
That's a very good question, and in fact, most of our patients are on PPI, and then the chromogranin can be falsely elevated. So we definitely want these patients to be evaluated by endoscopy and DOTA scan. Chromogranin is easy to do, but it has got some fallacies. But you are right that if we have a baseline in chromogranin and the patient is not on PPI, you can use it as a screening tool. But in our center, we do more do this type of resections or just bending and no resection and follow these patients with endoscopy and DOTA scan for 6 months, another 6 months, and if there is nothing, then we don't follow. But I must accept that there are no definitive guidelines available. Gradually the guidelines are also changing, because in periampulary up till now we were not doing, and now we are doing ampulectomies for neuroendocrine tumors, and also these patients are doing well. So I think this is a dynamic situation. Nobody has got very good experience. We have just submitted a series of 105 neuroendocrine tumors, and they have accepted in GI, and probably next month you will see in the publication. Yeah. So any other questions, I will be happy to answer.
There's one question.
So if you have one lesion, you need to do endoscopy to look for others?
So duodenal endocrine tumor, the pathophysiology is different from gastric neuroendocrine tumor. In duodenal neuroendocrine tumor, you may find many tumors. You have to go up till D2 and D1, but gastric neuroendocrine tumors are totally different. Gastric neuroendocrine tumor, like type 1 gastric neuroendocrine tumor, will happen because if somebody is having atrophic gastritis, there is achlorhydria, there is secondary hypergastrinemia because of the antral gastrin secretions, and then there will be multiple nodules in the stomach. So they are known as type 1 gastrinoma. Type 2 are also gastrin dependent because of the tumor arising from multiple MEN syndrome. So if you find a gastric neuroendocrine tumor, best way is to see the gastrin level. If gastrin level is high, the patient is safe. But if patient is having a sporadic neuroendocrine tumor, that is known as type 3 neuroendocrine tumor, they are gastrin independent and they are more malignant. So if you see gastric neuroendocrine tumor and gastrin level is normal, you must think about type 3 gastric NET, and these require more aggressive tumor surgeries or maybe big ESDs. But for duodenum, we don't have classification.
Yes, true.
Yeah. Okay.